Hello everyone, this is Arije Docas from Group Software Engineering Machine Learning 13, and I'll be taking you through our project titled as in Supervised Tree-Based Architecture for Predicting Anti-Malarial Treatment Failure in HIV Co-infected Patients. Our keywords will be the anti-malarial treatment failure, clinical staging, HIV malaria co-infection, pseudolabel propagation, supervised learning, and tabular classification. The contents of our presentation, we have the introduction, related work, problem statement, research questions and objectives, research contributions, methodology, system architecture, dataset description, all model architectures, model evaluation results, explainable AI results, model compression and results, machine learning operations, model deployment, limitations, conclusion and feature work, references, and the acknowledgement. So in our background and introduction, in Uganda, predicting anti-malarial treatment failure is difficult because hospitals often have limited patient records and incomplete clinical data. At the same time, HIV weakens the immune system, making some malaria treatments less effective. Most rural clinics still rely heavily on manual clinical judgment, which can delay treatment decisions. So our research therefore developed a predictive risk scoring system that uses biomarkers such as the CD4 count, hemoglobin, white blood cell count, and platelets to estimate who clinical staging and treatment failure risk. Because approximately 75% of the dataset lacked labels, we used the semi-supervised learning. Semi-supervised learning allows the model to learn from both labeled and unlabeled patient records instead of ignoring the unlabeled data. We also selected tree-based models because they handle nonlinear medical relationships better and are easier to interpret compared to deep learning models. So next, to go to the related works. Several researchers have previously worked on HIV resistance prediction and anti-malaria treatment studies. For example, Liu and Han focused on HIV drug resistance monitoring, while Khalid and Cesarman used machine learning approaches for HIV resistance prediction. Other studies focused on drug distribution logistics for statistical reviews instead of predictive clinical systems. But however, previous systems had three major limitations. First, many models lacked interpretability, meaning clinicians could not easily understand how predictions were made. Second, most studies relied entirely on supervised learning and could not effectively use enabled data. Third, many systems were not designed for low-resource healthcare environments like rural Uganda. Our work improves on this by combining some supervised learning, explainable AI, and lightweight deployment suitable for low compute clinical settings. This major challenge in this project was severe label scarcity. About 75% of the dataset did not contain verified World Health Organization clinical stage labels. Traditional preprocessing methods such as mean or median imputation distort the natural structure of medical data. Mathematically, this causes variance collapse in the feature space. When variance collapses, patient differences become hidden and high-risk patients may incorrectly appear similar to average-risk patients. This becomes dangerous in the healthcare because the system may underestimate the treatment failure risk. To solve this problem, we use the robust and multivariate iterative imputation methods for their pseudo-label propagation in order to preserve the true biomarker relationships. Our research aimed to answer four major questions. First, what is the relationship between the CD4 count and anti-malaria treatment failure risk among HIV-positive patients? Second, which anti-malaria treatment is most effective across different HIV immune levels? Third, which geographical regions show the greatest overlap between HIV prevalence and anti-malaria resistance? And finally, we should immunocompromised patients be moved earlier to stronger second-line treatments? These questions are highly relevant in Uganda, where HIV malaria co-infection still affects many vulnerable communities. Our study produced 4 major contributions. First, we developed a predictive treatment failure risk score using CD4 counts and regional resistance markers. Second, we built a drug effectiveness mapping system that identifies which ACT treatments remain most effective under HIV-related immune suppression. Third, we mapped overlap zones where the HIV prevalence and the anti-malaria resistance are both high. This can help Ugandan public health authorities prioritize interventions in high-risk districts. And finally, we proposed an AI-assisted clinical support system that can help HIV-positive patients receive the correct treatment faster. Our methodology started with data collection and pre-processing. We cleaned the datasets, handled missing values, normalized biomarker features, and separated labeled from unlabeled data. Next, we trained multiple semi-supervised and supervised machine learning models. The models generated pseudo-labels for unlabeled samples and continuously improved learning through iterative training. After evaluation, we selected the best performing model and optimized it using model compression techniques. And finally, we developed a deployment pipeline suitable for the low-resource healthcare environments. We used 3 datasets, the PF8 dataset, which contained approximately 33,000 records. The IDH dataset contained 761 records. The MTM dataset contained 1,642 records. The features included the CD4 count, hemoglobin, white blood cell, and platelet count. Since about 75% of the data was enabled, normal train test split would have caused biased evaluation. We therefore used a ground truth only test split, where the testing set contained only the physician verified labels. This ensured the evaluation reflected true clinical reliability. Our exploratory data analysis also showed strong relationship between the immune biomarkers and the treatment outcomes. For example, patients with a lower CD4 counts generally showed higher treatment failure risk. The EDA visualizations helped us identify important patterns in the dataset. We observed correlations between the biomarkers such as the CD4 count, hemoglobin, and treatment outcomes. Some biomarkers showed skewed distributions, while others showed strong separation between the high-risk and low-risk patients. These findings helped guide the feature engineering and the model selection. So we implemented several semi-supervised learning models. First was the label propagation. This method spreads labels through a similarity graph. Next, we shall go to the model architecture and the mathematical foundation, and we shall begin with the self-training GPC, which uses the Bayesian probability and the pseudo labeling to learn from enabled samples. XGBoost uses the gradient boosting to reduce prediction error through sequential decision trees, while the SHARP explains feature contribution. The label propagation and label spreading, they use graph-based learning where labels spread between similar patient samples. Co-training and retraining, they use multiple classifiers that exchange high-confidence pseudo-labels to improve learning from unlabeled data. TSVM extends support vector machines by maximizing the decision boundary using both labeled and unlabeled data. Bayesian hierarchical models and Gaussian process regression use probability distributions to estimate predictions and uncertainty. ElasticNet combines L1 and L2 regionalization to reduce overfitting and select important biomarkers. Then next we move to the model architectures. We shall begin with the label spreading architecture. which starts with the raw patient data, followed by cleaning, feature scaling, graph construction, and iterative label propagation, and two predicted labels are generated. Then the self-training XGBoost architecture begins with a label and unlabeled data. The model trains on labeled data first, predicts unlabeled samples, selects high confidence predictions, then retrains iteratively until convergence. Then the co-training architecture splits features into two independent fields, where two classifiers teach each other using confidence pseudo labels. The retraining architecture uses three classifiers, and pseudo labels are only assigned when at least two classifiers agree on improving reliability. The overall mathematical foundations explain the models learned, and while the architectures explain how the workflow of the patient data moves through the system. We also implemented the transductive support vector machines, and these ones use enabled data to maximize the decision margin. We further used the Laplacian regularized least squares, abbreviated as the LabRLS, to preserve the geometry of the data manifold. Another important model was the Bayesian hierarchical modeling, which captures uncertainty probabilistically using Bayes' theorem. We also implemented the Gaussian process regression, which predicts both outcome and uncertainty intervals. Finally, we used elastic net regression, which combines L1 and L2 regularization. Among the regression models, elastic net achieved the best R-squared value of 0.985. For classification, label propagation achieved about 93.9% accuracy, while self-training achieved approximately 92.8% accuracy, with a strong rock area undercurve score. TSVM and LabRLs also performed reasonably well. However, the best overall model was the self-training with Gaussian process classifier because it achieved approximately 94% accuracy with a strong weighted F1 score about 0.91. In healthcare, accuracy alone is not enough because clinicians must understand why predictions are made. So we therefore used explainable AI techniques such as the sharp values and the permutation importance. Sharp values explain how each biomarker contributes to the prediction. For example, the low CD4 count and the abnormal hemoglobin strongly increase the treatment failure. Permutation importance was also used to rank the most influential features by measuring performance changes when features were shuffled. This transparency is very important in Uganda because healthcare workers need AI systems they can trust before integrating them into the patient care. To make deployment feasible in low-resource hospitals, we compressed the models using the knowledge distillation, pruning, and quantization. Knowledge distillation performed the best because it reduced the model size to approximately 1.2 kilobytes, while maintaining almost the same accuracy and F1 score. This is important in Uganda because many rural clinics operate in limited computing power and unstable internet connectivity. A lightweight model, therefore, allows deployment on low-cost computers or mobile devices. The selected model was the self-training with Gaussian process classifier. We selected it because it combined strong predictive accuracy, strong F1 score, semi-supervised learning capability, and uncertainty estimation. The deployment pipeline includes pre-processing, prediction, explainability, generation, and clinician-facing outputs. The system can potentially support regional referral hospitals such as Mulagomba and Gulu Regional Referral Hospitals. Our MLOps pipeline focused on scalability, reproducibility, and deployment efficiency. The workflow begins with pre-processing and feature engineering. The data is then passed into the semi-supervised models for training, and pseudolabel generation. After evaluation, the selected model is compressed and packaged for deployment. So we also controlled the random seeds and hyperparameters to ensure reproducibility. Despite the strong results, the study had several limitations. The model heavily depends on the quality of the initial labeled dataset. Biases on the labeled data may propagate during the pseudolabeling. The system may also struggle when tested on unseen populations. Additionally, external clinical validation is still required before the large-scale deployment. Therefore, the model should currently be viewed as a clinical decision support and rather than a replacement for medical professions. In conclusion, this research demonstrated that supervised learning can successfully address severe label scarcity in medical datasets. The self-training Gaussian process classifier achieved strong predictive performance while maintaining explainability and lightweight deployment. Future work will involve integrating newer datasets, adding genomic resistance markers, improving prediction for severely immunocompromised patients, and integrating the system into hospital information systems. For Uganda, this research will demonstrate how AI can support healthcare delivery in the low-resource environments while maintaining transparency and clinical reliability. These are the references we used in our work, and we sincerely thank our supervisor, Mr. Galiwango Marvin from Makerere University, and all the dataset contributors for their support throughout this project. Thank you very much.